It's a pretty strange paradox in modern cardiology today.
Oh, it really is.
You have a patient, right, and they come in with an acute myocardial infarction, a heart attack.
And we're talking a severe one.
Right, a really severe one. And we treat them with the absolute most advanced technology available today. You know, drug-eluting stents, sophisticated P2Y12 inhibitors.
Maybe even advanced mechanical support if they need it.
Exactly. We throw the kitchen sink at them and we save the heart muscle. But then
a few days or weeks later, a complication pops up.
yeah. And this complication basically forces us to look all the way back to the 1950s for a solution.
It feels incredibly archaic, doesn't it? You're referring to the left ventricular thrombus, or LVT.
I am.
And the treatment standard for that for a very, very long time has just been vitamin K antagonists.
Warfarin.
Warfarin.
We have this entire cutting-edge ecosystem of care, but if a clot forms in the ventricle, the official guidelines essentially just say, give them the rat poison.
Which is, I mean, it's a harsh way to put it, but historically accurate.
Right. Meanwhile, we have these direct oral anticoagulants, DOACs, and they have completely revolutionized how we treat things like atrial fibrillation and DVT.
They really have. They changed the game entirely.
And so everyone naturally wants to use them for LVT because they're just easier. But strictly speaking, if you do that, we're operating in the dark. It's off-label.
It is off-label, and that is exactly the tension we are exploring today. You have clinicians out there who are essentially voting with their prescription pads.
Moving toward the DOACs.
Right, moving toward DOACs, while the major society guidelines are still very much holding the line for warfarin.
So the big question we need to answer for you today is, are we getting ahead of the data? Like, are we sacrificing patient safety just for the sake of convenience?
To figure that out, we are doing a deep dive into a really fascinating systematic review and meta-analysis.
Published in the Portuguese Journal of Cardiology.
Yes, back in 2023. And this isn't just, a single isolated case report. These researchers aggregated data from nearly 2,500 patients.
Which is a solid number.
It is. And they did this to see if the modern approach actually holds water against the old standard.
And just to set the stage for you, the listener, as to why this even matters, we aren't talking about some minor, trivial complication here.
No, not at all. When we talk about LVT, we are talking about a massive, massive spike in stroke risk.
The paper actually cites an odds ratio of 5.5 compared to patients who don't have a thrombus.
5.5.
Yeah, that is not a subtle signal.
No, it's a blaring siren. And the physiology here is really important to understand because it completely dictates the treatment timeline.
Walk us through that. How does this actually happen?
Well, this usually happens after an anterior MI. So you get damage to the left anterior descending artery territory.
The widowmaker.
Exactly. And that damage leads to what we call apical agenesis or dyskinesia.
Basically, the apex of the heart just
Stops moving entirely.
Right.
And when that happens, you have Virchow's triad in full effect.
Right, the three conditions for a blood clot.
Precisely. First, you have endothelial injury from the infarction itself. The tissue is damaged.
No.
Second, you have a hypercoagulable state because the body is dealing with systemic inflammation from the heart attack.
It's on high alert.
And third, and most importantly here, you have stasis.
The blood isn't moving.
The blood just pools right down there at the apex because the muscle isn't squeezing it out effectively.
So you end up with this stagnant pool of inflammatory blood just sitting there in the main pumping chamber of the heart.
It's a ticking time bomb for an embolic stroke.
And most of these strokes happen within the first 4 months post-heart attack, right?
Yes, that is the critical window. So the standard operating procedure is to anticoagulate immediately. You have to thin the blood.
But here is where the study gets really interesting. It covers data from the years 2018 to 2021.
Which puts us right in the thick of the DOAC revolution, if you want to call it that.
I do want to call it that. It was a massive shift. So this meta-analysis covers 14 different studies from that era.
Including 2,498 patients total.
But when you look at the breakdown of those patients, you can still really see the dominance of the old standard of care.
You definitely can. Out of those patients, 1,867 were on vitamin K antagonists, warfarin,
Wow.
while only 631 were on DOACs.
So that's roughly a 3-to-1 split, which makes sense, I guess. I mean, if you follow the American College of Cardiology or the European guidelines strictly, you're writing a script for warfarin.
You are following the rulebook.
But we need to talk about who is actually in these studies. This is a meta-analysis, but the underlying data, it isn't from randomized controlled trials, is it?
No. And this is probably the single most important caveat for you to keep in mind throughout this entire deep dive.
Let's highlight this.
Of the 14 studies they looked at, 9 were retrospective observational cohorts.
Okay.
And only 1 was prospective.
So mostly researchers are just looking back at historical patient charts?
We are just looking back. And that introduces a massive potential for selection bias, specifically what we call confounding by indication.
Break that down for us. What does confounding by indication actually mean in the clinic?
Think about how a doctor makes a decision right at the bedside. Let's say you have a patient with renal failure, or a mechanical heart valve,
Okay.
or maybe a really chaotic social situation where you genuinely worry about their ability to adhere to a medication schedule.
You're probably going to put them on warfarin.
You are, because you can actively monitor their blood levels to ensure they're taking it, or simply because DOACs are outright contraindicated if their kidneys are failing.
Ah, I see. Whereas the stable, relatively healthier patient, the one with good insurance, good kidney function, a stable home life.
That patient gets the convenient modern DOAC.
Precisely. So when we look at the results and compare outcomes, are we actually comparing the drugs? Or are we just comparing the baseline health and socioeconomic status of the two groups of patients?
That is the million-dollar question. The meta-analysis tries its best to statistically adjust for this, of course.
Right.
But without a large-scale, randomized head-to-head trial where everything is perfectly controlled, there is always going to be some noise in the signal.
The researchers definitely acknowledged this heterogeneity. But let's look at what they actually found in the data, starting with the drugs themselves. Because when we say DOACs, we aren't talking about all of them equally, are we?
No, it's basically a two-horse race in this data set. Rivaroxaban represented about 49% of the DOAC usage,
Almost half.
and apixaban was right behind it at almost 42%. Dabigatran and edoxaban were practically negligible.
Why do you think that is? Is there some specific pharmacological reason clinicians prefer the factor ZAD inhibitors over the direct thrombin inhibitors for LVT?
It most likely comes down to simple dosing familiarity and the broader label approvals. Rivaroxaban and apixaban are the absolute workhorses for atrial fibrillation and venous thromboembolism.
Doctors write those scripts in your sleep.
Exactly. There's also some lingering concern with dabigatran regarding gastrointestinal side effects and maybe some specific pharmacokinetic issues in post-MI patients.
But primarily it's just a comfort thing.
Primarily, yes. Cardiologists are incredibly comfortable prescribing apixaban and rivaroxaban.
Okay, let's get right into the meat of it, the efficacy. Because the primary job of these drugs is to prevent that clot from breaking off and throwing an embolus to the brain.
That is the main goal.
So what did the pooled analysis actually show regarding stroke and systemic embolism?
Well, they looked at the raw event rates first. In the DOAC group, there were 109 events.
Okay.
In the VKA group, the Warfarin group, there were 386 events.
Which makes sense since the group was 3 times larger.
Right. But when you run the actual meta-analysis, the odds ratio comes out to 0.86 in favor of DOACs.
0.86. So that actually trends toward DOACs being better at preventing strokes.
Yeah, it trends that way, yes. But we need to talk about statistical significance here.
The p-value.
The p-value was 0.50.
Oh, so in statistical terms, that is a total wash.
It's a wash. There is absolutely no significant difference. The confidence intervals cross unity. So scientifically, we cannot sit here and say DOACs are better at preventing stroke.
But in the clinical world of non-inferiority trials, no difference is actually a massive win, isn't it?
It absolutely is a win. Think about it from the patient's perspective.
Right.
If I can give you a drug that doesn't require weekly blood draws, doesn't require strict dietary restrictions, and it works exactly as well as the difficult high-maintenance drug.
That is a huge clinical victory.
It is. The data strongly suggests that by using DOAs, we are not compromising efficacy. They are holding the line against stroke just as well as warfarin does.
What about the other side of efficacy, though? Actually getting rid of the clot. We don't just want to prevent a stroke, we want these clots to resolve.
Thrombus resolution, yes.
Yeah.
And this is super interesting because warfarin has a very different mechanism of action compared to DOACs. Warfarin works by inhibiting factors 2, 7, 9, and 10 in the coagulation cascade. It's very broad. I call it a shotgun approach.
And DOACs.
DOACs are highly targeted. They typically just hit one specific factor, like factor ZAN.
Yeah.
So there was a genuine theoretical concern out there in the cardiology community that maybe these targeted DOACs wouldn't be as good at actually melting an existing clot.
So they might stop a new one from forming, but they wouldn't bust the old one. What did the data say about that?
Resolution was observed in roughly 69% of the DOAC patients
Okay.
versus 67% of the VKA patients.
Wow, that is incredibly close.
The odds ratio was 1.14, and again, a p-value of 0.50.
No statistical difference whatsoever.
None. So the fancy, modern, targeted mechanism works just as well at resolving the clot as the old shotgun approach.
It certainly appears so. But knowing how you look at studies, I feel like we have to sprinkle a little salt on this finding too.
We do, because thrombus resolution isn't a simple blood test. It is determined by imaging the heart.
And the studies in this meta-analysis probably didn't all use the exact same cameras, so to speak.
Exactly. They used a real mix of imaging modalities. You're basically talking about TTE, standard transthoracic echocardiograms versus cardiac MRI.
And what's the difference in terms of finding a clot?
Well, TTE is the standard bedside test. It's quick, it's easy, but it has real sensitivity issues, especially right down at the apex of the ventricle, where these specific clots love to hide.
It's fuzzy.
It can be. Contrast echocardiography definitely helps clear it up. But cardiac MRI is the undisputed gold standard. It sees everything.
So if one study in the meta-analysis used mostly MRI, they might look closely and find that the clot hasn't fully resolved yet.
Right. Whereas a study using just a standard bedside echo might look at the same patient and say, looks completely clear to me.
So you have this heterogeneity problem. If the DOAC studies leaned one way on their choice of imaging and the Warfarin studies leaned another way, it could completely skew the resolution rates.
It definitely could. But honestly, even with all that noise in the data, the signals across the studies are remarkably consistent. The efficacy really does appear equivalent.
All right, let's pivot to the aspect of this that actually keeps cardiologists awake at night: safety.
Yes.
We're talking about bleeding risks. And this is where the specific context of the post-MI patient becomes absolutely crucial.
We have to remember who we are treating here. These aren't just relatively healthy people taking a blood thinner for AFib.
Right. They've just had a major heart attack. They almost certainly have a new stent in their coronary artery. So what else are they already taking?
That is the elephant in the room. Almost all of these patients are on DAPT, dual antiplatelet therapy.
So usually aspirin plus a potent P2Y12 inhibitor like clopidogrel or ticagrelor or prasugrel.
Exactly. So you take a patient, you put them on aspirin, you put them on a strong antiplatelet drug, and then you add a full-dose systemic anticoagulant on top of that for the LVT.
We call this triple therapy.
And triple therapy is a notoriously high-risk regimen for causing major hemorrhage. The risk of a severe bleed jumps significantly when you stack those drugs.
So when we look at this meta-analysis, we aren't just asking if DOACs are safer than warfarin in a vacuum. We are really asking which drug is safer when mixed into this specific triple therapy cocktail.
That is the exact clinical question.
And the expectation, generally speaking, is that DOACs should be safer, right? I mean, we see less intracranial hemorrhage with DOACs in all the big atrial fibrillation trials.
That is the expectation. But did it hold up here? The numbers are surprisingly tight.
Let's hear them.
For what they classified as any bleeding, the event rate was 8.7% in the DOAC group
Okay.
and 8.3% in the VKA group.
That is statistically identical.
It really is. Now, for clinically relevant bleeding, it hovered right around 7% for both groups.
And what about the less severe stuff?
For minor bleeding, DOACs were sitting at 11%, while VKAs were a bit higher at 15%.
Okay, so maybe a slight trend toward less minor bleeding with DOACs, but overall, there is no massive safety benefit.
No massive benefit shown here.
That's actually counterintuitive to me. I really would have expected the warfarin group, the patients dealing with swinging INRs and unpredictable blood levels, to bleed significantly more.
It is surprising.
Yeah.
But this brings us right back to how things are defined in clinical research. You mentioned the phrase clinically relevant bleeding.
Yeah.
Well, in a meta-analysis, you are entirely at the mercy of how the authors of the individual source studies chose to define that term. And in cardiology, we have a total alphabet soup of bleeding criteria.
Oh, absolutely. We have gusto, we have TMI, we have BARC.
Right, and those definitions are not interchangeable at all.
How so?
Well, the TMI criteria that stands for thrombolysis in myocardial infarction generally looks for massive hemoglobin drops. It's looking for big, obvious physiological insults.
Okay, what about BARC?
BARC is the Bleeding Academic Research Consortium. It uses a graded scale. So a type 1 bleed is very minor, but a type 5 bleed is fatal.
And gusto.
Gusto focuses heavily on whether the bleeding caused hemodynamic compromise. Did the patient's blood pressure crash because of the bleed?
So if study A in our meta-analysis uses TMI major to track safety, and study B uses BIARC3A, you are trying to pool data together that isn't perfectly aligned.
It's exactly like trying to compare apples to slightly different, maybe slightly redder apples. It's messy.
And the authors of the meta-analysis noted this.
They noted significant heterogeneity here, but honestly, even with all that methodological messiness, the fact that there was no significant difference in safety is actually a huge relief.
Why is that a relief? Just because they aren't worse?
Yes, it means DOACs aren't causing more bleeding in this high-risk population.
Yeah.
And there was a very real fear early on when doctors started moving away from warfarin because warfarin was so easily reversible with an antidote.
Though, to be fair, we do have reversal agents for DOACs now, too.
We do, thankfully. Though they are extremely expensive and they aren't always immediately available in every single small hospital pharmacy. But yes, the old fear of we can't reverse it if they crash is largely a thing of the past.
I want to circle back to the triple therapy aspect for just a second. Since we know triple therapy causes bleeding, and we see no difference in bleeding rates here, does this study tell us anything about the actual dosing the doctors used?
What do you mean?
Like, were these DOAC patients on a full 20 milligram dose of rivaroxaban, or did the doctors use a reduced dose because they knew the patient was also on aspirin and clopidogrel?
That is a critical blind spot in this entire analysis.
They don't know.
The authors explicitly state that they could not fully investigate the specific doses or the exact duration of treatment because the original 14 source studies just didn't report them consistently.
That is incredibly frustrating.
It is.
Because clinically, a lot of doctors might instinctively lower the dose of the DOAC if they know the patient is already on too strong antiplatelets. They want to mitigate that bleeding risk.
It's highly likely that happened. We know from other big studies, like the Pioneer AF-PCI trial, that using lower doses of rivaroxaban combined with P2Y12 inhibitors reduced bleeding compared to warfarin.
So they might be applying that logic here off-label.
Exactly. But since this specific LVT meta-analysis couldn't stratify the patients by dose, we really don't know the truth. We don't know if the equal safety profile we are seeing is because DOACs are just inherently safe at full dose.
Or because the doctors were being smart and dose reducing on their own.
Right. It effectively brings us right back to the inherent limitations of observational data.
We are seeing the results of individual clinical judgment just as much as we are seeing the actual pharmacology of the drugs.
That is exactly what we're seeing.
So if we look at the final scorecard here, we have a draw on stroke prevention, we have a draw on clot resolution, and we have a draw on safety and bleeding.
A three-way tie.
If the scorecard is completely tied, why is there such a massive ongoing push in the medical community to switch everyone over to DOACs? Why not just stick with the devil we know?
Because the devil we know comes with a massive lifestyle burden for the patient. And this is where we have to step away from the p-values and look at the actual human experience.
The quality of life argument?
The paper refers to it as the pharmacological profile. Let's look at warfarin. It has a very narrow therapeutic window. We aim for an INR level of 2.0 to 3.0.
Right.
If your level is 1.9, you essentially aren't protected from having a stroke.
And if it's 3.1?
You are at a significantly higher risk of having a major bleed.
That is a tightrope to walk.
It is, and staying in that window, what we call the time and therapeutic range, or TTR, is notoriously difficult to achieve. It requires frequent clinic visits, constant blood draws, and endless dosage adjustments.
Not to mention the dietary policing.
Oh, the diet is a huge factor.
You eat a kale salad for lunch, your vitamin K goes up, and suddenly your INR drops. You have an alcoholic drink with dinner, it might shoot up.
Now contrast that burden with a post-MI patient. This is someone who is already dealing with so much. They are starting cardiac rehab. They have a handful of new daily medications to manage.
They're dealing with the psychological trauma of having just survived a heart attack.
Exactly. So looking that patient in the eye and telling them, hey, on top of all this, you also need to come down to the anticoagulation clinic every single week to get stuck with a needle. And you need to strictly monitor your leafy greens.
It's a really heavy lift. It's overwhelming.
It is. Versus the DOAC conversation, which is basically take this one pill once a day, see you in 3 months.
The fixed dosing and the total lack of monitoring with DOACs is just a massive advantage for patient adherence.
And we cannot stress this enough. Adherence equals efficacy.
A drug only works if you actually take it.
Right. If a patient gets completely fed up with the warfarin monitoring and just quits taking it, their stroke risk absolutely skyrockets.
And that's a variable that is so hard to capture in a retrospective study, right? How many of those warfarin failures in the data were actually just compliance failures?
It's impossible to know for sure, which is why the authors of the paper ultimately conclude that DOACs really should be considered a first-line strategy moving forward.
Largely for this practical reason.
Yes, they are non-inferior in clinical outcomes, but they are vastly superior in practicality and quality of life.
So if the data is this supportive, even if it is just observational, and the mechanism makes biological sense, and the quality of life is undeniably better,
Yeah.
why are the official medical guidelines lagging so far behind? Why is this still officially considered an off-label treatment?
It really comes down to the inertia of evidence-based medicine. The major guideline committees typically demand large randomized controlled trials before they will change a Class I recommendation.
They want the gold standard proof.
They do. But here's the very real problem with that demand. LVT is a relatively rare complication of an MI in the modern era.
Because our frontline treatments have gotten so much better, we treat heart attacks quickly in the cath lab now. So far, fewer people develop those severe wall motion abnormalities that cause the clots in the first place.
Exactly. The incidence rate has dropped. So, to power a randomized controlled trial effectively for LVT today, you would need to enroll thousands of patients.
Across dozens of centers.
It would take years to complete and cost tens of millions of dollars. And quite frankly, since these DOACs are already going generic and the clinical community has already largely made the switch on their own, there is very little financial incentive for any pharmaceutical company to actually fund that trial.
So we are essentially in a situation where the quote-unquote perfect trial is just never going to happen.
We might be waiting for Godot on this one. This meta-analysis we just reviewed, with its 2,500 patients, represents the best big-picture look we are likely to get for a very long time.
Which really puts the individual clinician in the driver's seat. They have to synthesize this data for themselves.
They do.
And seeing a non-inferiority signal across 2,500 patients essentially gives them the scientific permission to prioritize their patients' quality of life.
That is exactly how I read it. It validates the current trend we're seeing in clinics everywhere. It tells the doctor, you aren't crazy for doing this, the data supports you.
It's a really fascinating look at how the practice of medicine actually evolves in the real world. Sometimes it's a massive breakthrough discovery in a lab, and sometimes it's just confirming that the easier, simpler way is also the safe way.
And for a patient who is actively recovering from a severe heart attack, easier is a valid medical outcome in itself.
That is such a vital perspective to keep in mind. Well, we've unpacked the statistics, we've debated the bleeding risks, and we've explored the complex reality of operating in an off-label world.
It's a lot to consider.
It seems the new contender, or rather the modern standard, is definitely here to stay, even if the official rulebook hasn't been reprinted yet.
I think that is a very safe bet.
We'll leave it there for today's deep dive. As always, the best patient is an informed patient, so keep asking questions about your own health data, and we'll catch you on the next one.